Okay, it's 6:01, so we'll go ahead and get started. I want to welcome everyone to tonight's CME, Puberty, When Is It Too Young, and Thyroid Disorders. A couple of housekeeping items. If you have questions during the presentations, go ahead and put them in the chat box, and my colleagues will be monitoring that, and we will answer those questions at the end of the program around 7-ish. The second housekeeping item is that there's going to be an evaluation sent in the chat box towards the end of the presentation, and it will also be emailed to you. It only takes 4 minutes to fill out, so if you wouldn't mind taking the time to fill that out, we really appreciate the feedback on how to improve future CMEs and gives us ideas for topics. I will go ahead and introduce our speakers now. Dr. Roberts will speak first on thyroid disorders in children and adolescents. Dr. Roberts went to medical school at the Geisel School of Medicine in Dartmouth, Lebanon, New Hampshire. And she did a residency at the University of Washington, go Huskies. She also did her fellowship at the University of Washington in pediatrics endocrinology. And Seattle Children's has been fortunate to have her on staff since 2017. Her clinical interests are adolescents with type 1 diabetes, general endocrine disorders, congenital adrenal hypoplasia, and Turner syndrome. She enjoys treating children and adolescents with endocrine disorders and diabetes and establishing close relationships with them and their families. The next speaker will be Dr. Parisa Salahi. She is also in the endocrinology and diabetes department. She went to medical school at the University of Nevada School of Medicine. She did a residency at Children's Hospital of Orange County, and she did her fellowship in pediatric endocrinology at the Children's Hospital of Los Angeles. She is the clinical director for Prader-Willi Syndrome Clinic, as well as a clinician at the Gender Clinic, which makes Prader-Willi Syndrome and gender-affirming care parts make more sense, having both of those focuses together. So without further ado, I'd like to introduce Dr. Roberts, and she can get started with her presentation. Thank you so much for coming tonight.
Great. So my 30 minutes of this hour is going to be discussing thyroid disorders in children and adolescents. Sorry if there's a little background noise. My 3 kids are running around upstairs, so I apologize for that. So today's talk, we'll first talk a little bit about thyroid hormone. Then I'll spend a lot of time talking about hypothyroidism, both kind of the diagnosis as well as the management. And then if I have time, I'll speak a bit about hyperthyroidism. I may have to kind of speed through that part. And we are, because the second half of this talk will be Dr. Salahi, and we will take questions for both talks at the very end. So feel free to put them in the chat, but we'll address them all at the very end to make sure we have adequate time for both presentations. So an endocrine talk would not be complete without some sort of drawing of a hormone axis. So this is my very rough drawing of the thyroid hormone axis. So it starts in the hypothalamus. You have the signaling from TRH, thyrotropin releasing hormone, which then stimulates the pituitary gland to release TSH, thyroid stimulating hormone, which then causes the thyroid gland itself, which sits in the neck, to release thyroid hormones. And thyroid hormones, T4 and T3, feed back at the level of the pituitary and the hypothalamus to then downregulate those hormones. So thyroid hormone exists in circulation either as T4 or T3. It is the only use of iodine in our body, and the 4 in T4 refers to 4 molecules of iodine, and the 3 in T3 refers to 3. T4 is the more kind of predominant form that exists in our body. T3 is known as the more active form, and it tends to be the form that exists more in the target cell. There are intracellular deiodinases that also help regulate thyroid hormone activity, and these serve to either convert T4 to T3 in the target cell. They also can convert T3 and T4 to reverse T3 or T2, which are the inactive forms of thyroid hormone. So thyroid hormone really has an impact on pretty much every part of your body, so every cell type. Increases metabolic rate, increases heat production, oxygen consumption, protein catabolism, encourages long bone growth, has a role in CNS maturation, particularly in children under 3, and it increases the sensitivity to catecholamines, which is the primary reason we see the symptoms of hyper and hypothyroidism is related to that feature. So starting with the case, so this patient is a 4.5-year-old male referred for poor growth. He's also had a poor appetite, cold intolerance, and dry skin, developmentally doing well, and has normal energy, but is a low-key kid. And here you can see a little snippet from his growth chart, which concerningly shows he's really fallen in length from the 25th percentile to below the 3rd percentile. And in endocrinology, we really like our growth charts and use that as kind of another vital sign when evaluating a child. So you get some labs. The thyroid, the TSH is quite elevated, 150, and the free T4 is low at 0.3, consistent with hypothyroidism. Also, there's some evidence of anemia, slightly elevated LFTs, and a slightly elevated CK, which we can see with profound hypothyroidism. Before I move on to talk about kind of this classic symptoms of hypothyroidism, this is a real growth chart. So this is a real patient. And as you can see, once the hypothyroidism was addressed, he caught up quite nicely. And so has a very beautiful growth chart following appropriate treatment. So symptoms of hypothyroidism. Fatigue is often a symptom due to decreased adrenal responsiveness. Often there's decreased appetite and metabolic rate. We do often see elevations in LDL cholesterol. So if a patient has elevated cholesterol and also has hypothyroidism, you want to repeat those labs once the thyroid hypothyroidism is addressed. Often we see mild weight gain. This is where the growth chart is really helpful in pediatrics. So if you have a child who's gained a lot of weight, but also is quite tall and growing well linearly, it's very unlikely to be hypothyroidism as a cause of the weight gain, versus if someone has weight gain and then isn't growing well linearly, that raises concern for some sort of endocrinopathy, including hypothyroidism. With pretty profound hypothyroidism, you can get skin changes, puffiness and thickness due to accumulation of hyaluronic acid. This happens around the eyes, the dorsum of the hands and the feet. You can also get increased water retention and a hoarse voice. Constipation, cool hands, dry skin, slow hair growth. Often reflexes are slowed, and then just slowed speech and response time, which is another interesting feature. Often with kids who have really profound hypothyroidism, once they have their hypothyroidism corrected and addressed, they kind of go the other direction. They often can kind of almost appear like they have ADHD for a period of time because they're so the stimulation and the shift is so dramatic in terms of the their ability to kind of focus and sit still. And so it can be, often we see a bit of a deterioration in school performance right after profound hypothyroidism is treated. Long-term effects of hypothyroidism, so delayed myelination and hypoplastic neurons, delayed growth. So oftentimes, if hypothyroidism is not treated for a period of time, you may not have complete catch-up growth. So the patient that we demonstrated was still pretty young, so had a lot of opportunity to have catch-up growth. But if that had gone on for a lot longer, it may have not reached his full kind of genetic height potential. Pubertal delay can occur. We also can see precocious breast development related to the really elevated TSH can stimulate the FSH receptor. And with this, you also can get increased ovarian follicles that form, and you can be at increased risk for ovarian torsion. So any adolescent or pediatric case that has ovarian torsion, you need to screen for severe hypothyroidism as a potential cause. You can also have decreased libido, erectile dysfunction, oligospermia. So Hashimoto's thyroiditis, which was the cause in this patient, is the most common cause of hypothyroidism where there is sufficient iodine. So most of the cases that we see are related to Hashimoto's. Hashimoto's is due to lymphocytic infiltration of the thyroid, and that causes destruction of the thyroid gland. Initially, you can get kind of a release of thyroid hormone as the gland is being destroyed and get kind of your hashitoxicosis phase of hyperthyroidism, but that's always transient. And then you end up with either normal thyroid function or decreased thyroid function, depending on the level of destruction. You may have a a large goiter, or you also can have a kind of small and scarred down thyroid gland later on in the process. And ultrasound tends to show kind of a classic heterogeneous echo texture with increased vascularity. And the way that we diagnose Hashimoto's is by looking for thyroid antibodies. So we look at the anti-TPO and anti-thyroglobulin antibodies. And if either one of these is positive, the patient has Hashimoto's thyroiditis. The titer itself isn't super helpful, and we also don't follow titers. So once someone has positive antibodies, they have positive antibodies, kind of the end. We don't check again typically. Um, Additionally, just because someone has positive antibodies and has Hashimoto's thyroiditis doesn't mean they're ever going to develop clinically significant hypothyroidism. So in pediatrics, it's been shown that about 1/3 of patients who have antibodies, so have Hashimoto's thyroiditis, end up needing thyroid support, so end up having clinically significant hypothyroidism. So two-thirds or the majority of patients with thyroid antibodies don't ever need thyroid hormone replacement. And nothing really happens. So as I'll get to our referral algorithm, we often don't see those patients who just have thyroid antibodies and aren't needing thyroid hormone replacement. Other things to think about when you diagnose Hashimoto's, so celiac disease can also go along with Hashimoto's, and if you have celiac and your TSH is elevated even after going on a gluten-free diet, then concern about Hashimoto's. You always have to think about Addison's disease and adrenal insufficiency in particular, and this is really important. And this is why we, as endocrinologists, don't tend to start levothyroxine, with the exception of babies, without seeing the patient. Because if someone has adrenal insufficiency and they have hypothyroidism, and you treat the hypothyroidism prior to treating the adrenal insufficiency, you then metabolize any remaining cortisol that's there and precipitate an adrenal crisis, which can be life-threatening. So you always, so if you are diagnosed a patient with both adrenal insufficiency and hypothyroidism, you always treat the adrenal insufficiency first with stress dose steroids for at least a few days prior to even thinking about initiating levothyroxine. Always thinking about Turner syndrome, as that can have higher rates of Hashimoto's, and then any other autoimmune condition. Other causes of hypothyroidism, so it's not always Hashimoto's. Sick thyroid is something we see in particular when thyroid labs are done in the inpatient setting. And it's kind of your body's compensatory response to a severe or a significant illness. And we can see all different combinations of thyroid function tests, but you can often see a rise in TSH in one phase of that. You can also get subacute thyroiditis, which is typically post-viral and comes with a painful thyroid gland. Typically antibodies are negative, and this is typically transient. Iodine deficiency can occur. We have seen this rarely in kids who are very restrictive in their diets. You can also get this with iodine excess. So, and this has been seen with seaweed, and particularly sometimes we think of this with babies who have hypothyroidism, and the mom is drinking a lot of seaweed soup to help with breast milk production, and that iodine actually gets passed through the breast milk, and we can see an impact on the thyroid gland. So the excess iodine ingestion also causes temporary hypothyroidism. There's kind of an escape effect after 10 days, so it's not something that needs treatment or is permanent. A history of head or neck radiation exposure or surgical removal. Different drugs can cause hypothyroidism. And then always have to consider central hypothyroidism, which would present where you have a inappropriately normal or low TSH, and then a low free T4. And typically this is in a patient who you have a suspicion. So they've had radiation to their brain. They have other central defects like a cleft lip or palate, things that are making you think they could be at risk for pituitary problems. So management, so the treatment of hypothyroidism is levothyroxine, which is very stable, has a very long half-life. One kind of key pearl is that so levothyroxine is very sensitive in terms of it likes to bind with other things in the stomach. And so we tell patients to avoid calcium, iron, or soy milk or soy formula with ingestion. So if they're on a multivitamin or iron, taking that at a separate time of day so it doesn't impair absorption of the levothyroxine. If they're old enough, we ask them to try to take it on an empty stomach at least 30 minutes prior to eating. Because it has such a long half-life, if they miss a dose, it's okay to double up the next day. if we do, as we do lab monitoring to help adjust the dose, anything containing biotin in it, in terms of a vitamin supplement, can interfere with the free T4 assay. So that needs to be stopped at least a few days prior to the lab draw. And then in pediatrics, Armour thyroid and T3 are not recommended treatment. So Armour thyroid is kind of desiccated thyroid gland, has T4 and T3, but it's not regulated at all. And so it's not something that we recommend be given in pediatrics or adults for that matter. T3, it's interesting. There is some adult literature that's coming out that's suggesting maybe there could be a role of T3 treatment in patients who have hypothyroidism and clinically are still symptomatic even with T4 treatment. The idea is to kind of add T3 to that treatment. It's not been, studied well or recommended in the pediatric population. So as pediatric endocrinologists, we don't typically use T3. So when to refer. So this because thyroid disorders and thyroid questions come up a lot, we do have on the Seattle Children's website an algorithm that can help you as pediatricians kind of figure out if it's a patient that should be referred to us, or if there are other things that can be done prior to that referral. First of all, a note: if the patient is less than 2 and there's a concern for hypothyroidism, that is not only someone that should get referred to us, it's someone that we should get a phone call about. So I don't have time today to talk about congenital hypothyroidism, but it's considered really kind of a medical emergency, because we know that delaying treatment, even by a few days, can really have neurodevelopmental outcomes that can be poor. So if you have a newborn screen that's positive, or someone under 2 with concern for hypothyroidism, that would be a time to call our provider to provider line and speak with one of us. And typically, depending on how clear it is, we will start treatment. It's one of the few times we will recommend treatment before they see us. But this is our referral algorithm for older than 2. So we break it down into the 2 to 7-year-old and then 8 and older. And really the difference is, as you'll see on the next slide, I'll show the 8 and older is really the TSH threshold. So we have a little bit lower TSH threshold for referral for the younger kids. So here on the left side, so TSH, if your TSH is elevated, but it's less than 7, so normal TSH is typically up to 5.5, and then your free T4 is normal, we ask you to check antibodies. And if antibodies are negative, it's very unlikely to be pathological. We just recommend rechecking in 4 months, or if they're really symptomatic, you can recheck sooner. If their antibodies are positive, then they are at higher risk of developing clinically significant hypothyroidism. So we recommend that they get repeat TSH and free T4 in 2 months. And then if the TSH is normal or less than 7 and the free T4 is low, so that would be concern for central hypothyroidism. The free T4 assay is actually not great, especially at that 0.6 to 0.8 range. So there's a better test that can be sent called equilibrium dialysis, and they typically can send that on the same sample that was already sent. So you don't have to do a separate lab draw. And this is a much more precise measurement of the free T4. And if that is normal, then great. Then we don't worry. If the free T4 by equilibrium dialysis is still low, then that would be kind of a non-urgent provider to provider review, depending on the clinical scenario. If the TSH is greater than 7 in this age group, that's where we would want to see them. And so this is the greater than or equal to 8-year-olds. And the only thing that really changes here is 10 as the threshold for kind of automatic referral. And then also in terms of if they're antibody positive, so they have Hashimoto's, or negative, the recheck time period is a little bit different. So if they're antibody negative, recheck in 6 months. And then if antibodies are positive, recheck in 3 months. And if their thyroid labs are normalized and they're antibody positive, typically those patients can probably be checked every 6 months to a year or sooner if symptoms develop, but they may not ever develop clinically significant hypothyroidism and may not ever need to see us, which would be kind of good for them. Oh, good. I have about 10 minutes. So the next case, so switching gears a little bit to hyperthyroidism. So this is a 14-year-old female with some anxiety and heat intolerance. She's had increased appetite and weight change, trouble falling asleep, fatigue during the day, and heart races during exercise. Her blood pressure is mildly elevated and her pulse is tachycardic. So you get labs. TSH is low, suppressed. Free T4 and T3 are both elevated. So consistent with hyperthyroidism. So hyperthyroidism, you typically get increased cardiac output and decreased peripheral resistance, increased sensitivity to catecholamines, which causes a lot of the symptoms, increased appetite, but often they either have weight loss despite increased appetite or no weight gain, heat intolerance, fatigue, and they can get proximal muscle weakness. So often we can ask them to do a squat in the exam room, and they can't really stand up from it because they have muscle weakness. Thyroid stare, and then increased bowel movement. So often they have more frequency of bowel movements, but not necessarily diarrhea. TSH is often quite suppressed, less than 0.1, and sometimes the free T4 might be normal, and children can have kind of T3 predominant hyperthyroidism. So we typically don't check a T3 level with hypothyroidism concerns, but for hyperthyroidism, we do check a T3 and monitor that. So when your labs indicate that someone is hyperthyroid, the first step is to kind of try to determine the cause. And often the most common cause, which I'll get into in the next slide, is Graves' disease. So you want to check for antibodies that would help you determine, does this patient have Graves' disease? So you check a TSI, so thyroid stimulating immunoglobulin. We also check Hashimoto's antibodies, so the anti-TPO and anti-thyroid globulin antibodies, because the hashitoxicosis or hashitoxic phase of Hashimoto's can be hyperthyroid. Also, we often see positive Hashimoto's antibodies even with Graves' disease, so you can have both. You can do a radioactive iodine scan. I will say this is often something that's tested for us in endocrinology on our various boards, but it's not something we tend to do a ton in practice. We tend to go more by antibody studies. But this is if you're not sure what's going on. So this would show increased uptake throughout with Graves' disease. It would show an increased uptake in one area with a hot nodule, which is pretty unusual in pediatrics, and then little to no uptake if it's hashitoxicosis or thyroiditis or exogenous thyroid ingestion. So Graves'
Dr.
disease.
Roberts,
Oh, yes.
there we go. The slides are matching up now. They weren't
Oh,
moving
no,
for a
I'm
second,
sorry.
so you're good.
So Graves' disease is kind of the most common cause of hyperthyroidism that we see. Thyroiditis, someone that's Hashimoto's, as was already discussed. Thyroid ingestion, a hot nodule. Extremely rare is a TSH secreting pituitary adenoma. I've never seen that before. And then here are some other very rare causes of hyperthyroidism. But I would say Graves' disease and Hashimoto's thyroiditis are the most common causes when we see hyperthyroidism. So Graves' disease it results from antibodies that bind to the TSH receptor and cause it to be constitutively on. So they stimulate thyroid production and release. And it's the most common cause of non-transient hyperthyroidism. Often they have a pretty large boggy goiter. You can check a TRAB level is one lab assay you can do, and that looks at inhibitory and stimulating antibodies, but it will be really positive with Graves' disease, or the TSI, a thyroid stimulating immunoglobulin level, is what we typically send at Seattle Children's. And you may have Graves related eye disease, and the eye disease and Graves' disease is something that isn't necessarily going to be impacted by treating the thyroid manifestations of Graves' disease. So often we rely on our ophthalmology colleagues to help if it's severe in terms of eye disease. So management, the only medication approved for pediatrics for pediatric Graves' disease is methimazole, and this prevents formation of thyroid hormone. Of note, it doesn't prevent the release of thyroid hormone that's already been formed, and so often there's a bit of a lag in the effect. The most common side effect we see is a rash. You can get an itchy rash with methimazole. We're usually able to treat through it with some antihistamines, but that can occur. We also can see transaminitis, so we monitor LFTs. We can see agranulocytosis. So we monitor for this with labs, with the CBC during treatment and before. And also if a patient with who's on methimazole has a fever or has a sore throat, we recommend getting in a CBC to make sure they're not neutropenic and immunocompromised because they can present with sepsis related to kind of fever and neutropenia. You can rarely get an ANCA vasculitis and a polyarthritis. So methimazole, it's our only option for medical treatment. It's not our favorite drug because it can have some significant side effects. Often in the acute phase of hyperthyroidism, if that heart rate is quite elevated, we do recommend treating with a beta blocker as well, either atenolol or propranolol. Propranolol is nice because it also blocks some T4 to T3 conversion, but it's not selective in terms of its activity, and so it's contraindicated with asthma. So in those cases, atenolol can be used. And this is something that typically after the first month, they're able to come off of once their thyroid hormone levels themselves normalize. The TSH can remain suppressed for quite some time, but the free T4 and the T3 hopefully will normalize fairly in the preceding few weeks to months after initiating treatment. And then we can offer definitive treatment either by thyroidectomy or radioactive iodine ablation. We tend to do this after the hyperthyroidism persists longer than 2 years because that tells us it's unlikely to go into remission at that point. Or if someone doesn't tolerate methimazole because of one of the serious side effects, then we have to consider definitive therapy. So I think I'm right on time. So I'll wait to address some of the questions at the very end, I think, and I'll let Dr. Salahi take it away.
Thank you so much, Dr. Roberts. That was wonderful.
I'm going to try to stop sharing my screen. Oh,
Looks good.
All right, great. I'm going to just move my camera over. All right. So we'll be talking about puberty, specifically precocious puberty. So when is it too young? And I do have a quick slide about disclosures as I receive grant support, and I've been a consultant on an advisory board. None of these disclosures are related to the talk we're giving today. Our learning objectives today are to understand normal versus abnormal pubertal development, to understand initial workup for early pubertal development, and to identify when to refer to us to manage early pubertal development. I'd like to start with some definitions. With puberty, it can be confusing because we think about early puberty depending on the clinical signs and symptoms we have. So I just want to go through some definitions, some words I'll be using. Thelarchy, which is breast development, gonadarchy, which is gonadal stimulation enlargement, so specifically enlargement of the ovaries and testes. This is specifically due to LH and FSH stimulation. Pubarche is appearance of sexual hair. Adrenarchy is the increase in adrenal androgen production, which is manifested by pubarche. So often when we talk about early pubertal development, we will use those two words, but they do mean different things. So for instance, pubarche would be the appearance of pubic hair without evidence of elevated adrenal hormones. Adrenarchy would be the evidence of pubarche with the increase in adrenal hormones. Menarche is the first menstrual bleed. Central precocious puberty, also you'll see them in my slides. I also abbreviate it to CPP, is gonadotropin dependent puberty, which is due to elevated LH and FSH, and this is what we consider true puberty. Peripheral precocious puberty is gonadotropin independent. So you'll have elevated estrogen, testosterone, and the subsequent estrogenization and virilization on physical exam, but your gonadotropins or your LH and FSH will be low. So let's talk about Tanner staging a little bit. This is something I'm sure we're all very well aware of, but just to review very quickly, when we talk about gonadarchy, we will specifically be looking as endocrinologists in the development of breast tissue as clinical evidence of estrogen production, and the enlargement of testes for clinical evidence of testosterone production from the testes. So these just go through the different stages of breast development, and also this is the orchiometer, which is the endocrinologist tool and friend, and this is how we measure our testicular volumes, and it's pretty easy. We just put a bead next to a testicle to compare the sizes, and that's how we come up with the testicular size. Pubarche is specifically looking at pubic hair, and so there's also Tanner staging for pubic hair. So often when we are evaluating a child, we will be commenting on Tanner staging for both breast development and pubic hair in somebody who's female, as well as testicular size and pubic hair for somebody who is male. Now let's talk about the gonadotropin axis. As Dr. Roberts was saying, endocrinologists love our hormone axes. So we're going to start with the hypothalamus and the pituitary gland. So you have gonadotropin releasing hormone coming from the hypothalamus, stimulating the anterior pituitary gland to make LH and FSH. This is released in a pulsatile fashion. And during early childhood, when somebody is not in puberty, this pulse is very low, and the amplitude is also low. But as you go through puberty, both the frequency and amplitude does increase. And this stimulates the anterior pituitary to release LH and FSH. If you are born with ovaries, then this would stimulate the production of estrogen and follicles. Specifically, LH would be the main player in the production of estrogen, and FSH would be the main player in follicle maturation. In individuals born with gonads that are testicles, the LH and FSH would stimulate the production of testosterone, specifically from the Leydig cells, and sperm production, specifically from the Sertoli cells. And of course, with all endocrine axes, there's always negative feedback. So estrogen and testosterone, high levels of that will feed back and suppress GnRH and LH-FSH production. Now, in general, other than a period of time called the mini puberty of infancy, which is around 1 month to 3 months of age, LH and FSH are low until the onset of puberty. The mini period of infancy we will not get into, but that is a time period where you actually have elevations of your gonadotropins just like you would have in puberty, but you don't typically have any clinical manifestations of it. LH and FSH are predominantly secreted at night during early puberty. Then as puberty progresses through later stages, then you will have higher levels of LH and FSH throughout the day. And this is the reason we will ask you to obtain labs early in the morning. Now, going into the adrenal axis, so the hypothalamus also releases corticotropin-releasing hormone, or CRH, which then stimulates the anterior pituitary gland to release ACTH, which then stimulates the adrenal gland. ACTH, when it affects the adrenal gland, affects a number of hormones to be produced. We will be concentrating on those that are related to our talk today. So when you look in the adrenal cortex, you have the 3 different zones of the adrenal cortex: the zona glomerulosa, zona fasciculata, and the zona reticularis. Zona glomerulosa creates the end product. The main end product is aldosterone. In the fasciculata, it's cortisol. And in the zona reticularis, we have the production of androgens, including DHEA, which is sulfated into the more stable form of, DHEA sulfate, as well as androstenedione, which in turn can will produce testosterone and estrone. Testosterone can also be converted to dihydrotestosterone and estradiol. So in the context of puberty and pubarche, what we'll be concentrating on is the zona reticularis and the hormones that are released there from that area. ACTH stimulates the secretion of DHEA and DHEA sulfate due to increased responsiveness of the zone to ACTH during the time of puberty. So the zona reticularis is not fully formed in the very early years of childhood, and then starting after 2 to 4 years of age, it starts to form more, and then it becomes more responsive to ACTH stimulation. During puberty, your ACTH level does not go up, so you don't see increased production of other hormones such as cortisol, but you will see that the zona reticularis will be more responsive to it, if that makes sense. There are some conditions that have been correlated to having higher levels of DHEA, DHA sulfate, and androgens, specifically low birth weight. So children who are SGA have higher responsiveness of this area. And then also those who have elevated postnatal weight. So those would be children who have elevated BMIs later on. Now, in terms of the timing of puberty, typically in females, the first evidence of puberty would be phylarchy, because the ovaries will be making estrogen, and estrogen will be stimulating that breast tissue growth. However, about 15% will have pubarche prior to phylarchy, so they'll have evidence of pubic hair prior to phylarchy. And then typically from the time of phylarchy, so the time of that first breast bud, Tanner stage 2 breast, to menarche, it's about 2 to about 2.5 years. So if a child starts having breast development, family is worried that they're going to have menarche, you can typically reassure them that menarche won't happen for at least another 2 to 3 years. In males, the first sign of puberty, true puberty, is testicular enlargement with testicle size over 4 cc's in volume or greater than 2.5 centimeters in length. Now, in terms of timing of puberty, everybody always brings up the NHANES survey. Now, this was a survey that took place between 1988 and 1994, and it was published in the early aughts. And it did show some differences between ethnic and racial groups. Specifically, they did subtyping for non-Hispanic white children, non-Hispanic Black children, and Mexican American children. And when they were looking at the median age of pubertal onset, for females, they did note that children that were non-Hispanic Black and Mexican American tended to have pubic hair, Tanner 2 pubic hair development prior to non-Hispanic white, and the same for Tanner 2 breast development. Menarche still tended to be very similar, but again, slightly earlier in non-Hispanic Black, Mexican American girls compared to non-Hispanic white females. But again, as you can see, despite the fact that the pubic hair and breast hair development were earlier, the menarche was very similar in terms of age. So all of them around after 12 years of age. In terms of the median age of pubertal onset for males, again, there was a bit of a discrepancy between the different subtypes, with pubic hair being seen earlier in non-Hispanic Black males compared to non-Hispanic white or Mexican American males. And in regards to Tanner 2 genitalia, so testicular enlargement, again, that there was an earlier pubertal onset in non-Hispanic Black males. This is some graphs that I found from UpToDate that I like because it shows you nice representation of what to expect in puberty at what time. As you can see, there's initial breast development, and then for females, and then you have an increase in your growth velocity with a peak height velocity just a few months prior to menarche. And as you can see, the height velocity definitely declines rather rapidly after menarche until the completion of puberty. Typically, we will tell families that due to the fact that the majority of your epiphyseal plate closure has occurred by menarche, the growth is only about 1 to 2 inches after menarche for females. In regards to the sequence of puberty in males, you can see that there is a increase in height velocity, and the peak height velocity happens in the middle of puberty rather than towards the end, as it is seen in females. Now, what is abnormal timing of puberty? So how do we define abnormal timing of puberty? Basically, we look at the time of puberty and the standard deviations from the mean. So if you have onset of secondary sexual characteristics that are outside of the 2 to 2.5 standard deviations from the mean, that would be considered abnormal. So for the definition of early onset puberty, this would be age 8 for females and age 9 for males. For delayed puberty, this would be breast development for females after the age of 13 and testicular enlargement for males after the age of 14. There was a study that came out in 2001 that did find some differences in rates of early puberty. Specifically, they defined that as menarche less than 11 and a half years in different racial and ethnic groups. They found that there was a higher rate of early puberty in children who were defined as Hispanic and Black. After that was white and Asian. Again, menarche less than 11.5 years might not necessarily be considered abnormal for us as endocrinologists. We do use 10 as our cutoff for abnormal menarche. But this just shows that there can be some differences based on racial and ethnic backgrounds. Interestingly, the difference seemed to be driven by weight. So females who were noted to have early puberty were 2 times as likely to be overweight in each of the different subgroups. Factors that can affect timing of puberty include your genetics. So family history is really important to obtain, specifically asking menarche for mother and female siblings and close relatives, or timing of puberty for males in the family. This can be a little bit harder to determine, but questions I ask for males in the family would be, do you remember when you stopped growing? Were you still growing after high school? Because that would be more likely for late puberty. Were you done growing in middle school, which would be more likely early puberty? And you can also ask questions about voice change and development of facial hair as markers of puberty to see if those are concordant with their peer. Environment can also also affect timing. So, you know, there's more research now on endocrine disruptors in the environment that could be affecting puberty, and there is evidence that certain endocrine disruptors are correlated with earlier timing in puberty. Also, psychosocial stress has been correlated with earlier puberty, and then increased weight or higher BMI can also affect timing of puberty. The opposite is true as well. Low weight can affect timing of puberty in the opposite direction, where it can cause delayed puberty. Even though I showed you this data that there can be some differences in puberty and different correlates regarding timing of puberty, this data does not change the threshold for age for precocious puberty. Using a younger age is controversial and can result in failure to identify pathology. So there are some, some places that will consider phylarchy at 6 for children of African American background to be normal, but again, this is very controversial, and we tend to still use the threshold of 8 because we don't want to miss any pathology. When you do look at somebody who has concerns for early puberty, it's really important to factor in things such as adiposity, family history, racial ethnic differences, the tempo of the puberty, which would influence your overall workup and treatment, and also your level of concern for this child. When I talk about tempo of puberty, I mean by how rapidly the puberty is progressing. So typically, you know, we talk about breast development to menarche is about 2 to 2.5 years. If you have somebody who developed Tanner's to breast and then had menarche a year later, that would be rapid tempo of puberty, and that would be more concerning than somebody who followed the more a slower tempo of puberty or more average tempo of puberty. When we look at the causes of precocious puberty, we want to divide it up into central etiologies and peripheral etiologies. So central, the most common is idiopathic, meaning we don't really have a good reason why it happened, and we've ruled out pathology. This is the case for 80 to 90% of females with early puberty, but this is not the case for males. There's more likelihood to have pathology in males who have central precocious puberty. Some things to look out for when you have somebody with central precocious puberty is CNS tumors. This could be a hypothalamic hamartoma or any other CNS tumor such as an astrocytoma or an optic glioma, which optic glioma can be seen in our children with NF1. Also, you want to, you could have a very rare gonadotropin tumor of the pituitary. Also, any CNS disorders such as static encephalopathy, low-dose cranial irradiation, and hydrocephalus could also cause precocious puberty. There are also genetic mutations that could cause precocious puberty, and this actually you'll find in a family history. So gain-of-function mutations of KIS1 and KIS1 receptor genes will cause precocious puberty, and then loss-of-function mutations of MKRN3 or DLK1 genes, which are inherited paternally, those will also lead to genetic precocious puberty. You can also have secondary precocious puberty from prolonged exposure to sex steroids. In terms of peripheral causes, we often worry about McCune-Albright. So if you have a child who has cafe au lait lesions, especially the ones that have the border of Maine and come midline, then we would worry about McCune-Albright. We would worry about adrenal tumors, severe primary hypothyroidism, as well as exogenous exposure to androgens and estrogens. If you have somebody who's male, you could also consider Leydig cell tumors, HCG germ cell tumors, as well as familial male-limited precocious puberty, also called testotoxicosis. This last one, they usually present very young, and they might have some enlargement of the testes, but never such an enlargement of testes that would be beyond mid to late pubertal size testicles, and they often don't progress in size. And for females, you would also consider ovarian cysts or tumors in your differential diagnosis for peripheral precocious puberty. In terms of premature adrenarche, which it would be isolated, and you wouldn't have signs of, for instance, estrogenization, you would worry about, in terms of pathology, adrenal tumors or non-classical CAH, exogenous androgens such as testosterone gel. There's been quite a few case reports of this in terms of male family members who are using testosterone gel and then having the child exposed to it, as well as ovarian testicular pathology, such as an androgen-producing tumor or cyst. However, the most common will be benign premature adrenarche. In terms of evaluation, those of you who have spoken to us will know that we always ask for a bone age. We find bone age is very helpful in looking at skeletal maturation. If you have somebody who's had prolonged exposure to estrogens or androgens, then you'll have an advanced bone age, and that's more concerning. We would ask you to get labs specifically in the morning due to the pulsatile and secretory pattern of LH and FSH. We would ask you to get an ultrasensitive LH. There are different assays for all of our hormones pretty much. The ultrasensitive LH is a much better assay and goes down to a much lower level. So for somebody who's a child who's going through, we're worried about early stages of puberty, you do want to get the most sensitive assay you can. This also holds true for estradiol and total testosterone. There are pediatric assays for estradiol, and then there are more sensitive total testosterone assays using mass spectrometry. We also always get thyroid function tests due to the possibility of hypothyroidism causing premature puberty. Additional workup to consider when you're worried about gonadarchy are tumor markers if you're worried about tumors. And then if you have a diagnosis of it, then you can consider imaging. So MRI of the brain for all males, regardless of age, who have central precocious puberty. And then definitely for females less than 6, because there's more likely to be pathology if they're younger. And then you can consider MRI for the brain for females between 6 to 8 based on the case. Again, this is also controversial, and you'll get a different answer from different endocrinologists. So the closer they are to the age of 8, then, and if the presentation doesn't have a rapid onset or any signs or symptoms that would be suggestive of a brain tumor, or there's a very strong family history, you might pass on the MRI. If you're worried about peripheral precocious puberty, you can also get a uterine or ovarian ultrasound or a testicular ultrasound. Or if you're worried about an adrenal tumor, you can get adrenal imaging. In terms of pubarche, again, the bone age and morning labs. However, this time we're going to be concentrating on the labs from the adrenal gland. So specifically, if you have pubic hair only, without any evidence of enlarged testes or breast development, then you would specifically be focusing on the adrenal labs. And this includes 17-hydroxyprogesterone, total testosterone, and DHEA sulfate. That's a good place to start. Additional workup to consider is an ACTH stimulation test if you are concerned that this child has CAH or congenital adrenal hyperplasia. Again, tumor markers and imaging could be the next step in workup. So as Dr. Roberts pointed out, we do have different algorithms to help you kind of work through the initial workup and when to contact us. So I'm happy to go through this with you. And before I forget, there was somebody who had a question in the chat in regards to the to body odor. So for us, pubarche is, we consider it pubic hair development, so pubertal hair, to be more of a sign of pubarche, true sign of pubarche. So pubic hair, and then also axillary hair could be part of that, and body odor and acne can also be part of that. However, it would be very unlikely to have body odor only without the evidence of pubic hair and axillary hair. So for us, if it's body odor only, just stinky armpits, without any other signs of pubarche, we wouldn't, we would probably just watch and we wouldn't do any workup at that point. In terms of the precocious puberty algorithm, so if you have girls under the age of 8 with breast development that's more than 10 or stage 2, or boys under the age of 9 with testicular enlargement, then we have an algorithm here set up in terms of what to do next. So if you do have this and they're less than 3 years of age, just refer straight to us, because that is very concerning due to the young age. If they're over the age of 3, they have headaches, visual changes, which would be concerning for a central process, or they have multiple cafe au lait spots, which could be concerning for a genetic condition, refer to us. It's always helpful if you do the bone age prior. If they don't have these clinical signs, then get the bone age for us. If the bone age is advanced more than 2 years, go ahead and refer to us, because that's more likely to have pathology. If the bone age is concordant with the chronological age, then we would look at the growth velocity. So if you're going through puberty, you tend to have a higher growth velocity than your peers who aren't in puberty because you're going through a growth spurt. So if you have a growth velocity over 8 centimeters a year, or you have abnormal labs, then you would refer to us. If you don't have a high growth velocity or abnormal labs, then we would just ask to follow up the child in 4 months to recheck the height and consider rechecking the labs. There are some children who might be entering puberty but still haven't fully entered puberty, and it's just important to monitor them closely to catch them. In terms of pubarche, so this is the development of early pubertal hair. Again, we use the cutoff of 8 for girls and 9 for boys. So if they, again, are less than 3 years of age, that comes straight to us. If they're over the age of 3 years, go ahead and get a bone age. If the bone age is advanced, go ahead and send to us. If the bone age is concordant with chronological age, then we'll want to know about if they have any further signs of pubarche or adrenarche. So that would include axillary hair, clitoral or penile enlargement, accelerated height velocity, or abnormal labs. If they don't have any of these other issues, then we would ask to follow up with the PCP in 4 months to continue to monitor them. Now, in terms of menarche, any child who has menarche prior to the age of 10, that would be considered abnormal and precocious and should be referred to us. Again, a bone age and labs would be appreciated to start the workup. In regards to treatment, if you have central precocious puberty, the treatment we would offer are gonadotropin releasing hormone agonists or GnRH agonists, also called puberty blockers. This comes as leuprolide acetate, which can be given every 3 months, either by IM or sub-Q, depending on the brand name we use, or Hystrelin, which is an implant that releases the GnRH agonist daily in a continuous manner. And we replace it every 1.5 years. There are some studies that show that it lasts longer in terms of continuous release of the medication, but the plastic that holds it does not last very long and tends to break apart and become very difficult to remove. So in conjunction with our surgeons who place them, we've come up with 1.5 years as a time to remove them. The goals for treatment is twofold. One is psychosocial. So there are the psychosocial considerations in regards to both the development of their body as well as the maturity level for going through puberty at that point. So, you know, if you have a 9-year-old who's menarchal, are they really ready to be handling the hygiene concerns that come with menses and going to school and everything involved with that? In terms of adult height attainment, you can improve adult height, final adult height, if the child is less than 6 for females, and studies show for males in general. Now, there are now a couple of studies that show that if the treatment for central precocious puberty is started after age of 6, then the improvement in adult height is minimal. And it really depends on the bone age advancement. So if you have a very advanced bone age, you're 7.5 when you come to us, then the puberty blocker is not going to help you with your final adult height attainment. It's not going to improve it. So we don't necessarily use this goal for treatment for children over 6. And treatment should be individualized. So we talk about this with families. Some families don't mind, don't want to use a GnRH agonist, and that's totally fine. We also offer menstrual suppression for families who would be more interested in menstrual suppression rather than pausing puberty. In terms of premature adrenarche, if it's benign premature adrenarche, We just monitor. There's no treatment that we give. So we would see the child about every 6 to 9 months until they reach the proper age for pubertal development. And where our goal is to catch central precocious puberty if it occurs, because there is a risk that these children who have early adrenarche could develop central precocious puberty. And thank you. This is the end of my talk.
Thank you so much, both Dr. Roberts and Dr. Slahi. That was a wonderful talk and very helpful. So we have some questions. The first question is, when should you repeat thyroid labs be drawn after changing levothyroxine dose?
Yeah, I'm happy to address that one. So typically we check thyroid labs approximately 4 to 6 weeks after any dose change because of the pretty long half-life that levothyroxine has. Checking any sooner isn't going to really give you enough time to see what that new dose is doing. So 4 to 6 weeks is our typical time frame after we've changed the dose. And then above that, it looks like what should be on our differential if a child is hypothyroid, symptoms with TSH and free T4 are normal. Oh man, a lot of different things. I think it's hard. It can be and that's the hard part, is symptoms that can be like hypothyroidism can also be a million other things. And so I just broad differential, the differential for things like fatigue are very, very long. And a lot of them are not kind of in the endocrine realm, but yeah, it's if the thyroid levels are normal though, then it's not the thyroid at least. And then it looks like the next question's for me
Yes.
too. When do we use T3? Is it better to combine T4 with T3? So I tried to touch on that a little bit, but we don't use T3 typically in pediatrics. In the adult population, there is some use of it in patients that have are still clinically symptomatic, even with normalization of their thyroid levels on T4. There's some thought that combo treatment could help. That's not something that's been recommended or rigorously studied in pediatrics. So we tend to stick with T4. There's kind of a rare circumstance where you use T3, and that is with something called consumptive hypothyroidism that's presents in the neonatal period, is extremely rare. And I guess it's kind of probably out of the scope of this talk, because it would, it's a very different mechanism than your typical acquired hypothyroidism Hashimoto. So in general, we don't use T3.
And then one question, MRI for females 6 to 8 is only indicated if the bone age and the labs are abnormal. Is this correct?
Hi, I think I touched on this in my presentation a bit. It's case dependent. So the earlier the age, the more rapid tempo of the pubertal development, then there would be more concern about a central process, and you would get an MRI of the brain. So for instance, 2 weeks ago, I saw an 8-year-old who went from Tanner to breast to menarche in 9 months. So although this child was 8 years old, the rapid tempo of the pubertal development was concerning, so I did order an MRI of the brain. So again, it's a case-by-case decision. There are some endocrinologists and different practices who will just blanketly get MRI on anybody who has central precocious puberty, but in our practice, we tend to look at the individual case a bit more.
Is there any other questions? I'm going to go ahead and, oh, here's another question. I have a child who has an elevated TSH at birth and been on low dose 25 milligrams Synthroid since birth, but now 4 years old and off Synthroid for 3 months and TFT. Okay, is it okay to watch and follow every 3 MPS now and monitor?
Yeah, I mean, usually so it sounds like this is congenital hypothyroidism, which, I didn't have enough time to really cover in my talk, but, congenital hypothyroidism can be temporary or permanent. And I can't give specific advice to your patient, but I will say for cases that end up being temporary and are able to come off of levothyroxine after age 3, if their thyroid levels are normal, I typically then dismiss them from my endocrine practice and don't typically check again as long as they've kind of been normal several months after stopping levothyroxine therapy. And they have a normal looking thyroid ultrasound on or thyroid on ultrasound, then I don't recheck unless clinical symptoms arise or something changes because it's typically they aren't necessarily at risk for acquired hypothyroidism, which is kind of in a different bucket than congenital hypothyroidism.
Thank you. I'll wait another minute to see if there's any more questions. I actually just unmuted everybody if they want to verbally ask a question. So it doesn't look like there's any more questions. I want to thank Dr. Roberts and Dr. Slahi so much for the presentation. It was very informative. Yes, and you will all be receiving the evaluation through your email also. And if you have any questions, please send it to your liaison and we will make sure we forward it to the 2 speakers and get your questions answered. Thank you so much, and we really appreciate you attending this event.